dislocated IOL.
Good morning. I would like to thank the Planning Committee, Dr. Chan, Dr. Schroff, for inviting me to speak on this topic. Today I'll be speaking about the surgical management of dislocated intraocular lenses. So the incidence of intraocular lens dislocation varies. Reports have gone as low as 0.1% all the way up to about 1.5%. And there is normally a predisposing factor to the dislocation. Most often it's trauma, but sometimes there are some underlying medical conditions that lead to dislocation, such as pseudoexfoliation, Marfan, homocystinuria, conditions such as that. The symptoms of a dislocated intraocular lens is a sudden, painless vision loss. But there are also those patients that come into your clinic and mention that they have fluctuating vision, normally positional with head or body position. The intraocular lens can be malpositioned in a couple of ways. One being subluxed or partially moved from its normal anatomic positioning, and the second is dislocation or complete movement from its normal anatomic position. The management depends on how that dislocation, how severe the dislocation or subluxation is, and what the underlying support structures are. If the capsular zonular complex is intact, one can reposition the lens into the bag or sulcus. If the lens is completely dislocated, or if the support structure is not intact, one can remove the dislocated lens in its entirety and place an anterior chamber intraocular lens. There are also ways to suture lenses. One may suture the lens to the iris, one may suture the lens to the sclera. I'm going to be focusing today mainly on scleral fixation techniques, and actually not with suturing, but embedding the haptics into the sclera. So I'm going to first acknowledge my colleagues for providing videos. This is a 23 gauge case. A prudotomy is performed, and a sterile marker is used to indicate the 3 and 9 o'clock meridians, and a scleral flap is created. One can use a crescent blade or a beaver blade, a standard square scleral. The interval in 6 o'clock. So a prudotomy is performed, 12 and 6 o'clock meridians are demarcated. A sclerotomy site is created at 12 and 6, about approximately 2 millimeters posterior to the limbus. That sclerotomy site is approximately 18 gauge. Here we see a scleral tunnel being performed with a 23 gauge cannula. That scleral tunnel should be 3 millimeters in length and end in the os, or the opening of the sclerotomy site. At 12 o'clock, it begins at the os and goes for 3 millimeters. This is a sublux lens, and so what we do is grasp the haptic. Now, because of that sclerotomy site, it doesn't matter where you grasp that haptic. You can grab it at the edge or even in the middle. Because the sclerotomy site is approximately 1.5 to 2 millimeters in length, it will externalize without breaking. This haptic has to be secured while the second haptic is externalized, and one can see that it centers well once it's externalized. The remaining lens capsule is removed because that support structure is no longer necessary. This part is the trickier part, where the haptics will be buried in the scleral tunnel. So what happens here is you can recanalize that scleral tunnel, which is probably hydrated and closed up a little. Then you take a 25 or 23 gauge disposable forceps. I would not use your non-disposable forceps for this type of thing. You grasp the edge and place it through the track and grasp it at the other end with a tying forceps. Same thing is done inferiorly. We see here that the haptic is embedded in the sclera. The lens is well centered, stable. The sclerotomy sites are then closed. And so, in conclusion, this is an evolving technique for scleral fixation. The haptics are embedded directly into the sclera. This avoids proline sutures. As many of us know, these sutures can cheese wire through sclera anywhere from 7 to 15 years or so. I'm sure many of us have had to rescue lenses that have fallen. There's good centration and great fixation with technique. Thank you.